purpose of this video is to demonstrate the release of the ulnar nerve at the elbow, frequently called the funny bone. It is neither funny nor a bone. It is the ulnar nerve. It is the nerve that provides sensation to the fourth and fifth fingers and innervation to the vast majority of small muscles in the hand, and is responsible for a great deal of fine motor coordination in the fingers. Injury to the ulnar nerve or severe chronic compression of this nerve by fibrous bands that we will shortly see can cause irreparable damage to the hand function. Usually this procedure is done if conservative measures have failed. This represents a compression, not an injury to the nerve in this procedure. Frequently and historically, the nerve has been mobilized, as one shall see, and moved to the front of the arm. In this case, the nerve is simply decompressed. In performing the dissection immediately under the skin, one must be very careful not to injure small superficial sensory nerves known as the medial antebrachial cutaneous nerves. Injuring those nerves in the process of getting down to the ulnar nerve can cause numbness on the back of the top of the forearm, as well as a very sore wound which may not get better for a long time. So extra care must be made to protect those nerves. Although it makes the procedure longer, technically the rewards for preserving the nerve are definitely worth the extra care. Bringing the incision down around the back of the elbow, one eventually begins to approach the fibrous bands which overlie the muscle that flexes the wrist, called the flexor carpi ulnaris. The proximal, or the top end of these fibrous bands, are known as Osborne's ligament. It is one of the points of compression of this nerve. As we begin to pan into this wound, one can actually begin to make out the ligament underneath the yellow fat. One sees a darker tissue, and that indeed is Osborne's ligament that can compress the nerve significantly. It is important to identify the ulnar nerve before going in to release the ligament, and one can see now at the top of the wound where my finger is, there's a yellow band, and that is indeed the ulnar nerve. The scissor is now directly over Osborne's ligament and undermining that ligament, and great care taken not to injure the ulnar nerve. The ligament is slowly released distally or towards the hand, all the while observing the ulnar nerve. One can see the pink tissue now under the fibrous bands, and these are that is the muscle of the flexor carpi ulnaris. You notice there's a longitudinal yellow fiber going across the muscle. That is one of the branches of the medial antebrachial cutaneous nerve, and great care is being taken not to injure that nerve during the course of the dissection. One can now see the nerve running inside and underneath the flexor carpi ulnaris, and some of the remaining fibrous tissue over the ulnar nerve is now being incised, thus freeing up the ulnar nerve from the compression. The nerve is gently teased apart from surrounding muscle, and many of the fibers that are still holding on to the nerve are being untethered in this dissection, and great care is taken in doing the dissection into the muscle to make sure there are no intramuscular fibrous bands still compressing the nerve, so the nerve is entirely free to move. One can now flex and extend the elbow to make sure that the ulnar nerve is not jumping to the front of the arm on top and one can see here that even in flexion the ulnar nerve remains in its bed. As well, the fibrous tissue over the nerve higher up in the arm is probed to make sure that there are no points of compression. Once that is done and the nerve is seen to be stable and not moving forward, one can actually simply close the skin at that point after obtaining control of the small bleeding points. If the nerve is deemed to be unstable, a greater dissection must be done and the nerve must be brought to the front of the arm, either under the skin or in some cases under the muscle. That is called a transposition. The skin is then closed in a routine fashion. There is no need for subcutaneous sutures. Sutures stay in the skin for about 10 days. Movement is allowed immediately, but no use of the arm is allowed for approximately 4 weeks.